Please start.
Good evening, respected senior faculties, doctors, embryologists, researchers, and dear colleagues. I'm Dr. Kajal Baleja, FNB Fellow from Sir Gangaram Hospital, and today we have come together for the IFS SIG meeting regarding the methodology workshop program where we'll discuss regarding the study protocols, methodology, and the data. I would invite Dr. Ruma Satvik ma'am to say a few words and give us some insight about today's discussion.
I'm going to quickly pass on the baton to Dr. Shweta Gupta to say a few words of encouragement, and then we move on to the talk by Dr. Deepak Modi.
Yeah.
And as we proceed, I think the scope of the workshop and what happens in future will be clearer to you.
Thank you, Dr. Ruma. I think on behalf of Indian Fertility, I welcome you all. And this is actually a group which has been, I think, by our president very carefully chosen, especially the mentor conveners. I think they have, whether it's Dr. Deepak Modi, Dr. Ruma, co-conveners, Bhavani and Archana. So, and a very important group. I think anyone who has a very much thinks very deeply about the science and the practice associated with the level of evidence and what is pico question and how do we analyze. I think this is a brilliant platform to understand it, to use it in day to day, how to interpret what type of study it is, what is statistical. There's a lot of behind the the level of evidences and what how you calculate the sample size and different statistical tests. So I think it's a brilliant platform and the team is excellent. And I'm sure this is going to clear our lot of basics which we in day to day practice we forget, and we just what everyone is practicing we practice, and how do we read the articles and the journal. So I think we all will get a lot of benefit from this, and this time this has been particularly combined with embryology, so it's very, I think, two unique fields which have come together. So my best wishes to the whole team, and of course this time the SIG is combined with the ACE, so all the best. Thank you, Ruma, for inviting me here. And I'm sure we all will gain a lot of things and especially clear our basics. So thank you very much.
Thank you. Thank you, Dr. Shweta, for those encouraging words. And we're all learning, I guess, with the process. So we really hope to incorporate some learnings, but also be able to teach young minds and hopefully the correct methods. Thank you so much, Dr. Shweta. Kajal, would you please invite the chairpersons?
Sure, ma'am. So moving forward with the first session of this evening, the chairperson of this session is Dr. Rupali Basi. So Dr. Rupali Basi, she is Senior Consultant IVF and Laparoscopy Surgeon in the Department of Obstetrics and Gynecology in Indraprastha and Apollo Hospital in New Delhi. Her special interests are fertility, preservation, and laparoscopy. Special achievements: Treasure IVF 2024 to 2026, Editor IFS 2024-2026. Faculty Fellowship in ART, Amity University, Noida. She is Commissioning Editor, Fertility Science and Research Journal. She have received many awards: Achievers Award, Fertivision Appreciation Award, Fertivision 2022, Best Executive Member of IFS 2018-2020, and first poster in the poster presentation IFFS. She has many publications also. I would invite our second chairperson, Dr. Tejshri Stroti. She's the Director, MedFem Women Clinic in Hoskas, Senior Consultant Obstetrics and Gynecology, Apollo Cradle Hospital, New Delhi, and Consultant IVF Unit, Sir Gangaram Hospital, New Delhi. Her current positions are Secretary, Delhi Gynae Forum South, Executive Member IFS, Executive Member NIGF Delhi. She has received IFS Fellow Gold Medal 2018 Award, and she is the Rising Star in IVF North Zone by IVF VOH. The areas of interest are reproductive medicine, fertility preservation, and high risk obstetrics and gynecology. I'll request the chairperson to invite our first speaker, Dr. Deepak Modi, for the talk. Hello.
I would request Dr. Rupali or Dr. Tejashree to invite Dr. Deepak Modi.
Can we have the speaker's intro slide, please? It is my immense pleasure to welcome Professor Deepak Modi. He's the scientific guide and head of Molecular and Cellular Biology Laboratory of ICMR. Welcome, Dr. Deepak, and it is a pleasure to listen to your talk today.
Can we start?
Sure.
Good evening, everyone, and it's an immense pleasure to speak to at this forum. And being a researcher at heart, it's like my moral responsibility to even instill this training and understanding of how to conduct clinical trials. And when I think me and Dr. Ruma were discussing that what should be a part of our SIG, that how do we inculcate this, we had a lot of thoughts and ideas, and we thought that let's begin with a small beginning where we try to give an overview of how do we do research and how do we decide a study design. And the study design always is based on a research question. And therefore, then we were like debating what should be our topic. And finally, we have come down to this kind of a webinar. And I think this should help you to understand how to do your own research. So the overview, the aim of this talk would be to assist you to think about research questions in a way you can improve the quality of research and ultimately clinical practice. So I must remind everyone here that do not look at research as a different entity from your clinical practice. You do research to assist you to improve your clinical practice and not just to publish papers. One of the biggest problems of research today is that the end goal of any research is when I ask people that, okay, why do you want to do research? And but the commonest answer I get is, oh, I want to publish a paper. Research is not to just publish papers, but research question or the research project has to be designed in a way that it changes a clinical practice or it helps us to decide what is good or what is not good for our patients. And for today's talk, I will use one of the examples of a drug, which we would use it as an example to understand how each of these research designs have. But before that, let's ask the question, what is research? Because there's a lot of confusion, a lot of unclarity. It's a very philosophical point that research is a systematic approach to obtain and confirm new and reliable knowledge. So please remember the words that research is about generating new knowledge and the knowledge has to be reliable. So therefore, it is a disciplined attempt. The word here important is disciplined attempt to address questions or solve problems. So it is either questions and solve problems through collection and analysis of primary data for the purpose of description, explanation, generalization, and prediction. I understand it's very complex, very philosophical, but to make it very simple, essentially it is to generate evidences so that it can help us to improve our clinical practice. And I must remind all of you that we do not use the word truth. A lot of people tell me that, oh, I'm doing this research to find the truth, whether this works or doesn't work. Truth is beyond the realms of research. The concept of truth is outside the productive realms of thinking by researchers. We say these are facts. So our job is to generate facts and generate evidences. So the research is a cycle. The cycle begins by a hypothesis that here's a hypothesis. You design experiments to address the hypothesis. Then you analyze the data, and then from the data, either you generate a new hypothesis, and finally, when you have generated adequate evidences, the hypothesis is either proven or the hypothesis is rejected. So several of the times when the hypothesis is proven over and over by researchers, then the accepted hypothesis becomes theories. So remember, whatever theories that we have today in our clinical practice was essentially a hypothesis at one point of time, which has gone through these several iterative cycles to lead to a theory. And there were several hypotheses which began, but then over the period of time, they did not stand the quality of the evidence and they were rejected. Now, what is the beginning of a good research project? So for this, you first need a design an experiment. How do you design the experiment? The designing of the experiment is dependent on the kind of question you are asking. And we will learn this with the example. So you first ask a question, you generate a hypothesis, and then you design the experiments and the loop continues. The beginning is a good question. A good question will generate a good hypothesis, and that will lead to a good design, which should lead to an appropriate outcome. So and this is very crucial, and identifying this research question, and this is my favorite question whenever people approach me with study design I should choose. And I tell them that for this, you need to have a good research question. What is your question? The question is not about, I want to see whether this happens or that happens. You have to figure out where the goal is. So here, the classic example is to get an idea of the destination before the journey begins. Your choice of study design will begin on the kind of research question you have asked. And this is the foundation of all good, or whatever we call as bad research. So what are the key features of a research question? The research questions typically classified into three broad categories. It can be a why question, which helps you to understand or give an explanation of why a particular drug is working. You can ask how a particular drug is working. You can change the focus, or what, which is essentially explorations, descriptions, prediction, and design solution. I know I'm talking very hypothetical right now, but as I move in my presentation, have some patience, these things will become clearer. So most of these why, how, or what question, you have to be very clear of what sort of a question you are asking, and then what is your hypothesis. What is a hypothesis? It is a possible testable answer to why and somehow questions expresses a relationship between two concepts and variable things. So just to make it very simple, a hypothesis is basically an educated guess that you think that by giving this drug, I can improve the IVF rates. So that's the hypothesis you have. So you begin by a simple question that, okay, this is a drug. This drug is possibly going to improve my IVF practice, and now I want to, or improve, let us say, the live birth rate, and now I want to test it. So the hypothesis is drug X treatment can improve the implantation rates, and therefore it can lead to an improved live birth outcome. So you have three layers here: your drug, your hypothesis that it is going to improve implantation rates, and what is the outcome I'm measuring is the live birth rate. So to get a better live birth rate, I need better implantation, and therefore I need drugs which are going to improve the implantation rates. So this is precisely the example I'm going to use. I'm going to spend about a minute here trying to explain you, and this is the example which I'll run through all over of how the question within this example can change and allow you to choose a study design. So let us say, because I'm an implantation biologist, I look at the endometrium, I'm slightly skewed towards this. We will start with a question that GM-CSF, because it is produced by the embryo, and GM-CSF should able to improve the IVF outcome in assisted reproduction cycle. So because it is produced by the embryo and the endometrium first sees GM-CSF, the hypothesis which we will put here is, since GM-CSF is produced by the embryo, perfusion of GM-CSF into the endometrium might help it to become receptive and hence improve the live birth rate. So what are the possible questions we can drive around the hypothesis? Your hypothesis is not going to change, but what is the effect? So here's a question, what? What is the effect of intrauterine GM-CSF treatment on pregnancy rates? This is possibly one question. The alternate question could be, why is GM-CSF better over endometrial scratching in implantation rate? So this is now a comparison study that I already have a standard of care, or I already have one question. Is my GM-CSF better? So this is the why question. Or how does GM-CSF help in improving implantation is a broad mechanistic question. And the study design for what, why, and how is going to change significantly. How many patients, whether it's going to be case control, so on and so forth, is going to change based on what sort of possible question you are asking. So now let's move to study designs. What are the different study designs? So your study design, typically, it can begin with case studies. So please remember that a single case report is not bad research. You begin with one single case report or a group of case reports, and you call them as case series. And you generate and you say that, okay, I gave GM-CSF to one patient and I got improved and I got an implantation. Otherwise, this patient was forever infertile. So I feel that it is working. Then somebody uses GM-CSF again and say, oh, I give it to 25 patients and it is working because I get in 25 out of 30 out of, let's say 20 out of 25 patients, I got implantations which were otherwise infertile. So I think the GM-CSF is working. So these are foundations of any hypothesis. Then you start with case control studies. Then you move to randomized control trials, which could be blinded or open label. Then there are cohort studies. And I'm going to dwell something on clinical trial of N of 1, which we will discuss in the later slides. So types of study design. So how do you choose which study design to use when? So when it is generating early evidences, somebody says, so I'll come up to you and say that, hey, look, I think that when I gave this drug to the mouse became pregnant very quickly. So I said that, okay, now let us do an early clinical trial. So then we'll give it to one patient, a group of patients. So you begin, and the first case report is usually a success story. Then you have case series, which are multiple cases, but this is largely anecdotal evidences. And then some of the clinics start giving it and keep observing what is happening, and this becomes observational studies. Please remember that these are not unimportant. These are very, very important because these are going to be the foundations of rest of the studies. But if you say that I already have randomized control trial published elsewhere by somebody else, and now I'm going to report a case study or a case series, you are doing no good. So you have to figure out that how much is the level of evidence already available with me. If there is no evidence, you can immediately start with case studies and case series, or you can do observational cohorts where I say that, okay, I treated with this drug to my 25 patients and the 25 patients are successful. They have no adverse outcomes. So basically, these are helpful in determining and generating early evidence. Once these early evidences are generated, you want to generate more robust and definitive evidence. So here now you get a little more serious, and now you take a more systematic approach. So these are less systematic approach. These are individual driven. Each one can decide their own sets of patients, own sets of criteria, and keep doing it. But now from step 2, you generate more robust and definitive evidence. And the beginning of that is a case control study, followed by randomized control trial or cohort studies. And for personalized medicine, currently now clinical trials of N of 1 are now proposed. So we will now discuss some of these using, again, back to our example of GM-CSF. So we will start with, when do I choose a case control study? The question let us ask is, do intrauterine treatment with GM-CSF improve ART outcomes? Now here we say that we did not have any evidence of it, or there was fragmentary evidence elsewhere in the world. We want to see if it's working in the Indian scenario, whether it's working for our group of patients, and therefore I want to generate a preliminary hypothesis. So you would design a small case control observational study. You're going to do some interventions, but it is still not going to be very intensive. And here comes the PICO format. What is a PICO format? The PICO format is patients, interventions, comparators, and outcomes. So you decide for every clinical trial, you must remember, you need to have your things in a PICO. So in this case, the PICO is my patients. Patients would be infertile women undergoing IVF. You will define the inclusion-exclusion criteria that I'm not going to take women with very thin endometrium, or I'm going to take women only with thin endometrium, or I'm going to take women who have previous implantation failures, or I'm going to take all the women that's walking into my clinic, because every woman should have a improved implantation irrespective of the cause. So you decide your group of patients in whom you're going to do this intervention. Then obviously the next is intervention, where you say, okay, my intervention is GMCSF. But now you become a little more specific that to all these women, I'm going to give how much of GMCSF and when I'm going to give. It's not going to be as random like in the case report or the case series where you started doing everything at random. Now here you do it very systematically. I'm going to give only this much of dose. I'm going to do it 2 days before the ET. I'm going to give these many units of GMCSF. Fair. What am I going to compare this data? So case series, case reports, case series, or observational studies usually don't have a control arm, but here you definitely need a comparator arm that if I leave these patients untreated, what is the outcome? So you cannot treat the same group of patients that, oh, these were infertile, now they became fertile. Here you're going to have a separate arm. So generally these are 2-arm studies where you have untreated controls, which could be infertile women, which could be infertile women with good prognosis, like male factor infertility, young women, old women, you can choose. So depending on your patient population, you will have a comparator group where you don't really do much of intervention, you just leave them like that. And then the most definite outcome is that, okay, I have my patients, I'm going to do the intervention, my parallel group is going to be left untreated, and what is the outcome I'm going to measure? Outcome is either I'm going to measure implantation rates, clinical pregnancy rates, or live birth rates. Because my hypothesis is that intrauterine installation of GMCSF should improve live birth rate, then my primary outcomes becomes a live birth rate. Here, the goal is to determine if the treatment which was claimed by others is working, is it even working? That if I don't give the treatment, I should get a certain implantation and live birth rate. But if I now give the treatment, my implantation and the live birth rate is going up. So this is the evidence generating thing. Usually these are small. You are not having very, very large numbers, but these are now systematic study, which you begin with a case control study. So what are the strengths of a case control study? It is excellent to generate initial data. It gives you very early evidence of safety because you don't know whether patients are going to respond to it adversely. Are there any adverse outcomes? So most of these are measured in the case control studies, obviously after the phase 1 clinical trials. But here we are talking of something which is already their safety is profile, but it is just generating safety data. Usually it is also done retrospectively, that I had a group of patients which I did not treat, I had a group of patients that I treated, and I just want to see outcomes. So you can even do it retrospectively or you can run it prospectively. Neither of them has any advantages or disadvantages. And it's way easy to conduct in most clinical settings. So those of you who have never done research before, I would not advise you to start with the full-fledged RCTs. You should always start with simple case control studies. To begin with, it has to be retrospective data, and then slowly you can move towards prospective. The problem with the case control studies is that there are innate biases, because here your control and the test groups are not randomly assigned. You are still having an innate thing that, okay, I'm going to treat these patients, I'm not going to treat these patients, and therefore you're not blinded. And then these have also statistical issues, because here you are not determining how many patients and how many controls should I have to get an adequate statistical power. And this is very crucial for clinical evidence generation, that is this difference statistically true? In one group, I had out of 20 patients, I had 10 becoming pregnant. In the other one, I had 13 becoming pregnant. So 3 additional patients becoming pregnant is good. But are these 3 statistically there, or they're just by chance? So this has a specific way of doing this calculations. Because you do not have any early data on it, you do not apply statistics here. data, you just take it as a random group of patients. But then you can calculate the power retrospectively. And in retrospective historical case control studies, you can have multiple confounders because you have not selected your patients with equal criteria. You have not selected them for a specific reason. You just had these treatments done in your clinic, and therefore you have this. So it is a good way to begin research. It is a fantastic method of collecting data. And usually this is one of the best methods in conditions where the outcomes are very hard to measure or they are long-term. So don't think that case control studies are inferior and some other trial is superior. All of them have their own issues and their own places. Case control studies, I personally love them. They're much easier to conduct and they generate way more robust evidences. Now let us move to the gold standard, which we call them as randomized control trials, and they're often referred to as efficacy trials. Here now you are not saying whether it's working or not. Here you are trying to say that by how much it is working, how much is the improvement, and in a more unbiased manner. So your question now you're asking is that I do have evidence that intrauterine GM-CSF has improved pregnancy rates, but by how much? This is the primary question you're asking. And usually RCTs are the acid test for effectiveness. Efficacy is the first thing you are measuring in RCT. The purpose is to get an objective, unbiased estimate of how much is the improvement. Is it just marginal improvement? A small population of patients are responding, or there were large numbers of patients are responding, and basically how many patients will finally benefit. And here now you need to have very well defined group of patients, the control group and the test group, and what is the outcome are very, very clearly defined way before you begin the study. So you cannot one fine morning get up and say, hey, let's start a RCT. Usually RCTs are planned at least a year in advance. You do a lot of brainstorming with your team. You identify your people, who is going to give you samples, what's going to be the drug, and so on and so forth. So now let us ask the question that do intrauterine treatment with GM-CSF improve the outcome? Here now you are doing the study to generate robust and unbiased estimate of efficacy. And again, here the PICO will definitely come into picture. Your patients are now going to be infertile women undergoing IVF. Here you can even subclassify and say that whether it is going to be all infertile women, is it going to be women with thin endometrium, or women above 35 years of age, or women with endometriosis, women who are poor responders, women who are recurrent implantation failures. You can have all these as a single group, or you can have only one group and say that, does this work in this group of patients? So it is up to you to decide. There is no gold standard. Nobody's going to tell you that you have to do for all women. So if you imagine that you want to put GM-CSF for all women and does it work for all women, irrespective of the cause of infertility, you have to do the trial in all women. But if you think that, no, I don't think that I need to put an add-on to women who has a good prognosis, I want to only do it in women who have recurrent implantation failure, then your inclusion criteria should be RIF or RPL, or depending on what you want to study. So your definition of your patient group population is extremely crucial here. Your intervention is not going to change, but it is going to be driven by what you have done in your case control study. So because your case control study is a certain dosage, a certain time of treatment did show an improvement, so you're going to now use it. So you cannot use RCTs to define dosages or to define, so you can define, okay, this dose versus that dose, but you cannot say, let me see which dose works. For that, you always do a case control study. Now here, the comparator group becomes very crucial. Here, you're not going to have a comparator group which is untreated controls, unlike in your case control studies. You're going to have infertile women who are going to be treated with same amount and same manner of saline or your drug carrier. And this is absolutely crucial, because how do you know that the improvement which you are seeing is simply because you put in a catheter, or the woman was mentally primed that मुझे डॉक्टर साहब ने कोई ट्रीटमेंट दिया है, तो therefore I'm going to respond. The innate biases, what we call, is something which is big problem in medical sciences, and therefore your comparator has to be treated exactly the same way as your patient. So they cannot come from different parts of the clinic or different clinics across the country. They have to be from the same region doing the same handling. And finally, your outcomes have to be more clearly defined. You have a primary outcome, which has to be a live birth in case of IVF. Secondary outcomes will be implantation rate and clinical pregnancy rate. And also you can have some exploratory outcomes like, did it improve the receptivity? So I want to test also by ERA that it improved in pregnancy because it improved receptivity, or it improved the expression of a set of genes, so on and so forth. So you can have some exploratory objectives, but your primary objective has to be clear, and the rest of the business is dependent on your primary objective, primary outcome. And usually people love it that it is blinded. So double blind is where your treating physician is blinded to the intervention in the comparator, and the data analyst is blinded to both patients, comparator, and the intervention. So they're only looking at group A versus group B and what is the outcome. They don't know what is group A, they don't know what is group B, and they don't even know which arm has intervention, the drug, as well as which arm has the placebo. So this is where you are really very, very stringent. So you're stringently evaluating whether it is working or not. So then you can also do RCT for superiority or non-inferiority. So let us say a company comes and says that, hey, GMCSF is there, but my drug is equally good or better, and let us test them. So you can now do a comparative trial where you can say drug X is better than GMCSF in improving outcome, or drug X is as good as GMCSF in improving outcome. So here your PICO changes slightly. Your PICO is still untreated, your PICO is still patients and your comparators, but your intervention arm is going to fall in three groups. You have the standard of care, you have the drug, and you can also have a no treatment arm. But the problem of a no treatment arm is, if it is already a standard of care, already your patients are using it, you have already shown previously that improves the outcome, withdrawing it from a set of group of patients sometimes is ethically a problem. So your ethics committee says that no, I'm not going to allow you to withdraw the drug. You only compare your standard of care versus the drug X. Please go ahead. So that is going to be dependent on how much is the strong evidence, that can you have enough evidence to say that if I withdraw both of them, can I have a control group? So this is how you would design a superiority trial. So what is the strength here? Obviously, it's gold standard because it generates the highest level of evidence, and there is a very limited chance of a bias. But the weakness is these are very, very difficult to conduct. It's not easy because you need blinding, you need which patients will go in the control arm, which patients will go in test arm. You can't say, acha, tum control mein jao, tum test mein jao. There are electronic ways of randomizing this. There are people who will do the randomization for you and tell you, so on and so forth. But these are extremely good for short-term outcomes. If you're looking, for example, in chronic diseases where your outcomes can come after 5 years, 3 years, 6 years, you cannot run RCTs. And usually RCTs are designed to run only 2 groups at a time, maximum 3. So if you want to compare multiple drugs at the same go, RCTs are difficult to conduct. And usually these RCTs are powered only for primary outcome. The biggest problem I have with RCTs is it assumes that one size fits all, that all the patients that I want to take should respond or they should not respond, or more than 80% of my patients should respond and less than 20% should not respond. And in conditions like infertility, which is so heterogeneous, it is very, very difficult, and therefore you will get subgroups which will respond, subgroups which will not respond, and you land up in trouble when a RCT says that, oh, it is not working. But when you look at the fine print, the RCT is done in a group of patients which really don't need a drug. Just to give you an example, I think it was last year, a paper came in JAMA, which said that treatment of antioxidants to infertile men does not improve live birth outcomes. And it was a big hue and cry that should we give antioxidants? Are we doing more harm than good? Blah, 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 blah. And it is a JAMA paper. You're going to swear by it. And only when you start looking at the fine prints and go to the methods of it, the inclusion criteria for the patient was all men. Now, why does a man who has normospermia with normal sperm count and normal motility and normal DFI would even need antioxidants? You give antioxidants to people who have a problem. So men with higher DFI, this study would have been amazing that, okay, men with higher DFI, I gave antioxidants, we showed that DFI comes down, and therefore we gave now do a RCT. Here, this RCT was done in all men. So now you have a heterogeneous group of men, and then you say it doesn't work, doesn't help. Same problem came with the RCT for PGTA. They showed that PGTA does not work, and they found that there was no improvement in live birth rate. And only when you look at the PGTA, it is all done in young women with good prognosis. Who the hell would want to do a PGTA in young women with good prognosis? This is not a group of women in which you would want to apply. You would want to apply to women who have recurrent failures. You want to apply to women who had previous histories of failures, or you want to apply to women who are aged, which produce more abnormal embryos. You don't apply to the right group and then say the RCTs generated the best level of evidence. This is not good scientific practice. So please remember, again, it goes back to the question that the question is, in this group of women, I think it is beneficial and therefore I would run this trial. So defining your question becomes the primary need in any form of clinical research. So now I'm going to move to the last segment of the talk, which is clinical trials of N of 1. This is not a very, very new concept, but in clinical practice, this is not something which is very famous, but it is something which is to be thought of. And that's where I think I included in my talk that many of these traditional clinical trials, for the reasons I just discussed, fail. Because all of this is an average effect. A standard clinical trial is going to average out all the patients and say that all these groups of MICA P is the same set, they have the same problem, and therefore they should have the same outcome. And this is not true. We have enough evidences to say that there'll be definitive responders and non-responders. And the problem is that in clinical trials, we kick out the real world patients because patients who do not fit our stringent inclusion and exclusion criteria are removed. And in a real world now, when it comes to the clinic, you cannot tell to the patient, oh, I think you don't fit into the inclusion criteria which I had used in my clinical trial, so I won't give you the drug. So it's not really a real life evidence. It is under a very controlled setting, the evidence is generated. So, and again, this is no personalized fits. Today we are talking of personalized medicine, and this RCTs do not fit into the criteria of personalized medicine. And therefore, the concept of clinical trial of N of 1 has been proposed, which is essentially personalization, where the patient acts as their own control group and by testing options in a random order over time. I'm going to explain this in the next slide. Usually it helps in chronic diseases like pain, sleep issues, high blood pressures, where symptoms are fairly stable. So it's not easy to also conduct clinical trials of N of 1, but it is possible to do that. And usually in rare diseases, and including in infertility, there have been some evidences to say that they do help, and they do not really require big RCT, but whether A patient is responding versus B patient is not responding, it's way easier to do it in a clinical trial of N of 1. So I'm going to give you an example here. The basic objective here is to determine the utility of an intervention for an individual, not for a group or a group of individuals, but not for the general. So the general reliability of RCTs is not applying in clinical trial of N of 1. So most trials are focused on population effects, but they don't have data to define unequivocal responders. So here what's done is, let us say you're measuring a biomarker, let us say hypertension. So you first measure at a baseline and say that, okay, the patient is hypertensive. You give an intervention of drug 1 and you find that the hypertension is come under control. Now you don't know whether this is because of actually the drug or something else. So you give a washout period, and in the washout period, you see that the hypertension goes back. So you can say that, okay, yes, probably this change was because of my drug. Then you give drug 2, which you feel the patient should respond, and you realize that the patient is responding, but is not responding as good as drug 1. So you give a washout and you exclude drug 2. Then you move to drug 3 and you find that the drug 1 gave again back the same response as what you find it in the first cycle. And you keep repeating this drug 1 and 2, drug 1 and 2 cycles till you finally reach a conclusion that, oh, at each time whenever I gave drug 1, I gave the best response. When I gave the drug 2, I did not get a good response. And finally, you say that drug 1 works better than drug 2. So this is something which is, and you repeat this over a group of patients and you say that, yes, this is how it's working. So when we have measurable changes which are time over time and which are fairly stable, this works amazingly well. So the clinical trial of N of 1 are participatory, where there's a continuous communication between the participant and the researcher, which enhances participant involvement in the study. Remember, in RCT, you're telling the patient, I'm going to give you something and I'm not going to tell you what I'm giving. Difficult to do in a private setup. I'm going to give you something and I don't even know what I'm going to give you. The patient is definitely going to run away from your clinic. So you really don't, so therefore these RCTs don't really are not feasible specifically in IVF, where most of it is in the private segment. So usually we should think of considering clinical trial of N of 1, where you're doing things in consultation with the patients. Then therefore they get personalized because you're going to tailor the participants' characteristics and preferences or beliefs. They're good predictive because aggregate series of N is equal to 1 identifies shared features in patients with common responses, providing the base for predicting response for specific treatments. And they're preventive in nature. The intensive data collection of N is equal to 1 trials can help you to determine early deviations from normal, and they can help you to determine the onset of disease. But the problem with clinical trials of N is equal to 1 or N of 1 is that the robust protocol. So for hypertension or chronic diseases, these are well defined, but they're not very well defined for most of the conditions, and they're not approved by regulatory. So today you say that, oh, I tested this new drug, or repurposing, or kind of can reconsider this drug for a treatment, and you go to a regulatory and you say, I've done a clinical trial of N of 1, they're not going to approve the drug. So regulatory trials are still RCTs. So just to summarize, tips for finding a good question. Please remember, if you are struggling, you are not alone. You have to work harder and harder. You have to talk to people. You have to talk to friends and colleagues. You have to consult mentors. And trust me, even at this point, I'm sure Dr. Ruma will agree that way before we start a clinical trial, we still talk to a lot of people and we do a lot of group meetings and try to come up with a study design. It's not something which you drive it overnight. It is a time-consuming process. You have to have a clear rationale that why do I want to do this study? Do I really need this evidence, or because I want to go to ESHRE next year and I want to show that I can do clinical trials, I want to do it? Don't do that. Do it for a reason, that why do I need this heavy-duty evidence? If I get this answer, will it make a difference to the existing theory? Does this question matter? Is it questioning the existing theory, and why it is interesting, into whom? Which class of patients are going to get benefited? Who's going to be changing, or who's going to be benefited by this entire business that I'm going to do? So the final comments is, please remember, you cannot keep dwelling about it. No trial is perfect. A case study and case series are as good as our RCT. Each one has their own pros and cons. It is all about research rigor. It is about clarity for which you're going to do this research. And then you justify your choices and designs. Nobody is going to press your neck that you should do a RCT and you have only done a case control. If a case control is good enough, you can just do it. And as far as you can provide your justification, and you should be able to say that, okay, this is case control. These are the limitations. This is a RCT, but these are the limitations. But you have to figure out that how your research fits into the existing body of knowledge, and how is it going to implicate, what are the implications on policy, practice, and what future research research is it going to drive to? Don't simply say that, oh, now that I've done one trial of 125 patients, a bigger multicentric trial is needed. These are all eyewash questions. That's not how research works. You have to think that whether this evidence is sufficient or you need more evidence. So to summarize, research is systematic approach to obtaining and confirming new and reliable knowledge. A research study will base on a good research question, and therefore it should be clear and specific. I hope I'm able to convince you on that. It will determine the type of study design, and a good study design should be able to give you the answer to the question you're asking. And the goal is that a research should be able to change the existing clinical practice and help in patient management. Thank you. I'm sorry I took a little bit of extra time, but I hope it's helpful. Thank you, and I'll be happy to take questions if there are any.
Thank you, Professor Deepak Modi. It was an honor. It was really an honor to listen to somebody as distinguished as you. And thank you for emphasizing that a good study begins with a good question, and a good question starts from defining the outcome. So, thank you so much for a lucid explanation. And I'm sure clinicians are going to get stimulated to start research now that they can find a good question and then choose a good study design. Thank you so much.
Dr. Tejashree, you could invite questions by participants, maybe one at a time. They could type their questions in the chat box. And if we have any, okay, we just have a comment from Dr. Sonia saying, excellent, Dr. Modi, very well explained.
Thank you so much, ma'am.
And if there aren't many, I have one for you,
Sure.
Dr. Modi. And RC, of course, I mean, the clinical question, the top of evidence pyramid, I mean, rests the RCT. And I can understand that there is an issue with feasibility, not finding the right population, and the recruitment takes a while because, not everyone, exactly as you explained, I don't know what I'm giving you. I don't even know if it'll help you. And where do you then find people? So, of course, then you ensure that even in a private practice, and if you have undertaken that trial, I'm just trying to play the devil's advocate, the other side, is ensure maybe that there are funds allocated for the study and that the patient does not have to pay for this. I think that is one ethical principle, that if you're trying out something new, the results of which you do not know, but you do know that it will not harm, it may or may not benefit, you have to ensure that the patient is not paying out of pocket for something that they don't know the results of. That's one. But I need to ask you, what is the strongest criticism of that view you have heard? I mean, your view is that RCTs are not perhaps the most feasible design. So are there other criticisms that you've heard to that view?
Oh, of course. I mean, I feel, I don't know from where this whole idea came that RCTs generate the highest level of evidence and the others are inferior to it. I agree with the part that RCTs generate good evidences. But that does not mean that there are sacrosanctual evidences and the evidences generated from other instances are inferior. I think the problem starts with the second assumption that, it's just from a case control study, so it's inferior. Do not assume that. Every evidence is a piece of evidence, and to build a good RCT, you need these evidences. So no research is a bad research. And that also does not mean that based on a case control study, you cannot change a clinical practice. So I believe
for long outcomes that take for a very long time, like cancer outcomes. I don't think RCTs are perhaps where you're trying to establish this drug leading to cancer, perhaps ovulation induction drugs. Would they lead to ovarian cancers? RCT is not the design.
Absolutely.
Or something where intervention itself or non-intervention itself becomes unethical. You would then want to do a cohort.
My biggest criticism to RCT is that it assumes one size fits all. Because you're believing that all your patients are going to be equal responders. And to do that, as researchers, we try to narrow down our inclusion criteria so tight that when the RCT goes to the real world,
Mhm.
most of the time nothing works.
I would
RCTs give extremely good ORs and extremely good responses. And then suddenly you find that when you sit across the desk, most of the patients are not responding because the patient populations are heterogeneous. So
precisely.
in that whole desire of having very homogeneous outcomes for our RCT, we are kind of missing out in the real world. So I do not put RCT on the top of the pedestal and then the rest of it below. I say they all generate different kinds of evidences, and it's best left to us that what evidence is I am convinced by to give it to my patients. I mean, there are instances as case controls are giving amazing outcomes, and when given to patients are giving amazing outcomes, but the RCTs fail to prove it. I mean, we know about PGTA or we know about this antioxidants which I spoke about. Would you want to stop your antioxidants to your patients who have high TFI just because a JAMA paper RCT, double-blind RCT has said it doesn't work?
Yeah. So we can go on and on about this,
Absolutely.
about
Yeah.
how you can homogenize population, but the fact remains that even in the antioxidant question, they stop at sperm counts and they stop at sperm motility. And I have been trying to research this myself. Why don't they take it to live birth, which is the eventual outcome?
Yeah.
And there are problems, I know, in designing and all that, but I would still, I mean, I'm on the other side of the divide that continues to believe that clinical research questions, especially questions of intervention where outcomes are short term, where you have your funds right, it RCT does generate the highest level of evidence. And not to say that cohort or case control do not. They have their place for specific kind of questions and specific kind of outcomes. But that will be, thank you. I think that was just brilliant, Dr. Modi. I think we need to move on to the next session.
So the
And
questions which I'll answer on the chat, I think we can move on to the next set of presentations.
yes.
I'll answer them on the chat. I mean, let's start with the next set.
Yes.
Moving forward with the next presentation, we have Dr. Anjali Raj. She is MCH Fellow, AIMS Delhi, and she'll be presenting her paper. So I request Dr. Anjali to share her screen.
So while she's sharing her screen, the purpose of the paper is largely to introduce the audience to certain concepts in study design and perhaps look at it through the lens of what you have just been taught. And if there are improvements, of course, we have a panel of experts who will comment on this and will probably take the discussion forward. So the first paper, Kajal, would you like to introduce that, or please introduce the experts?
So I'll introduce you to our experts. So our first expert is Dr. Gaurav Majumdar. He is the clinical embryologist at Sir Gangaram Hospital, New Delhi. He has 25 years of working experience in assisted reproductive technology and is President Academy of Clinical Embryologists 2024 to 2026. Our next expert is Dr. Shalini Gender, Professor, Department of Obstetrics and Gynecology, PJIMR. She's a faculty for infertility and IVF clinic, laparoscopy surgeon for fertility and endometriosis surgery. And our third expert is Dr. Bhavani Shekhar. She is Associate Consultant, Center of IVF and Human Reproduction, Sir Gangaram Hospital, Executive Member, IFS, and member of IFS Guideline Developmental Group on luteal phase support. So these are our experts for the discussion.
So we have with us Dr. Anjali Raj, who's MCH Fellow at AIMS Delhi. Welcome, Dr. Anjali.
Good evening, everyone. Am I audible? Hello.
Yes, you are.
Yes, you are audible.
Can I share my screen or shall I start the presentation?
Yeah.
Is my screen visible, ma'am?
Yes, your screen is visible.
Okay. Good evening, everyone. I'm Dr. Anjali. I'm first year resident in MCH Reproductive Medicine and Surgery at AIMS Delhi. My thesis is titled The Effect of Antioxidant Therapy on Semen Parameters in Men Undergoing Assisted Reproductive Technique Cycles, a randomized control trial. So coming to the background regarding this topic, so male infertility accounts for almost 50% of infertility cases worldwide, and abnormal semen parameters can be due to a wide variety of causes, which can cause elevated reactive oxygen species and cause redox imbalance. This contributes to sperm DNA damage and results in abnormal semen parameters. This can affect the fertilization, embryo development, embryo quality, and contribute to pregnancy loss. So the rationale behind my study is to provide antioxidants to reverse the possible oxidative damage that is present and to reinstate the redox balance state. So the conventional methods which are used for sperm sorting, such as swim up and density gradient centrifugation, are also centrifugation based methods and can contribute to oxidative stress. So we in this study intend to use microfluidics, which is a more gentler and efficient method, which allows a natural selection similar to what happens in the female reproductive tract. So these are the various antioxidants which have been studied in the past studies and literature, and they contribute to various. They have various effects on the sperm metabolism, maturation, motility, and the DNA. So the aim of my study is to evaluate the role of antioxidants in male infertility in improving semen parameters and reproductive outcomes in couples planned for ART cycles. The primary objective of this thesis is improvement in semen parameters, that is the concentration, total motility, progressive motility, and the morphology, which will be assessed by standard semen analysis and microfluidic technique. The secondary objectives are after the IVF, what is the fertilization rate, cleavage rate, blastulation rate, number of good quality embryos, and the clinical pregnancy rate, and also the adverse effects of antioxidants. Coming to the methodology, it is an open label randomized control trial to be done in the ART center of our department from June 2026 to June 2028. The sample size was calculated based on an RCT conducted by Patki et al., which evaluated the effect of antioxidants on semen parameters in infertile men. Semen parameters such as the concentration, motility, and morphology were selected as primary parameters. And after a literature review, we assume that the antioxidant supplementation will result in a clinically meaningful improvement of 30% in at least one of the key semen parameters. For this, we assumed an alpha of 0.05 and took a statistical power of 80% and calculated a minimum of 47 participants in each group. Considering a possible attrition rate of 10% during the 3-month follow-up period, the sample size was calculated as 52 participants in each group, making the total sample size for this population as 104. Coming to the eligibility criteria, we intend to include infertile couples undergoing ART cycles for male factor infertility according to the WHO criteria of semen parameters, such as concentration less than 16 million per ml, total motility less than 42%, progressive motility less than 30%, and normal morphology less than 4%, and willing to participate in the study. The exclusion criteria are azoospermia, hypogonadotropic hypogonadism, known karyotype abnormalities, active genitourinary infections, recent use of testosterone, and any history of testicular surgery, chemotherapy, or radiotherapy. The investigations that will be done at the baseline include a semen analysis to classify the patient, the individual as having oligozoospermia, asthenozoospermia, teratozoospermia, or a combination. And an abnormal semen parameter will be repeated to confirm the diagnosis. This is the consort flow chart. So after assessment for eligibility and enrollment, the patients will be randomized in 1:1 ratio to either receive antioxidants or no antioxidants. Both the groups will receive lifestyle modification advice. At 3 months, follow-up will include reassessment of semen parameters. Within 4 weeks of intervention, we plan to do a controlled ovarian stimulation, and the sperm sorting will be by microfluidic technique, and then an IVF will be done and the analysis of outcome. During follow-up, we intend to assess the compliance to therapy by assessment of empty packets of the drug. Adverse effects will also be recorded. So these are the interventions. One is that the antioxidant group will receive both antioxidant and lifestyle advice, and the other group will receive only lifestyle advice. Antioxidant blend of L-carnitine, coenzyme Q, zinc, lycopene, folic acid, selenium, and vitamin B12 and vitamin C have been selected. And lifestyle advice will include refraining from smoking, alcohol, and improving the physical activity and diet. Coming to the outcomes, the primary outcome will be a change in semen parameters after 12 weeks by standard semen analysis and microfluidic technique, including the concentration, total motility, progressive motility, and morphology. Secondary outcome will include the laboratory outcomes in IVF cycle within 4 weeks of completion of intervention. That is the fertilization rate, cleavage rate, number of good quality embryos, blastulation rate, and the clinical pregnancy rate, and finally the adverse effects of antioxidants. So since it is an RCT, I want to tell the PICO. P is the patient group, that is the infertile couples undergoing ART cycles for male factor infertility and willing to participate in the study. I is the intervention group, that is the antioxidant with lifestyle modification. C is the control group who will receive only lifestyle modification advice. And O, the outcomes, the primary outcome being the semen parameters, and secondary outcomes will be the embryological outcomes, clinical pregnancy rates, and the adverse effects. Regarding the literature review for my study, this is a similar study by Patki et al. Conducted in 10 study sites across India. It is a randomized, double-blind, placebo-controlled trial to assess the effect of an antioxidant blend versus placebo in improving semen parameters and DNA fragmentation index. So at 90 days follow-up, this was the antioxidant blend used, and at 90 days follow-up, they found that the sperm motility, DFI, semen volume, and sperm morphology all improved in the treatment group compared to the placebo group. So from this study, they concluded that antioxidants can be effective to reduce oxidative stress and thus improve sperm DNA integrity even in males above 40 years of age. However, the data is conflicting because this is a trial published in Fertility Sterility in 2020. It's a multi-center, double-blinded, randomized, placebo-controlled trial in 174 men with abnormal semen parameters. Here, 85 males received an antioxidant blend, while 86 males received placebo. 3 months after the intervention, spontaneous conception was planned, and during 4 to 6 months of the intervention, ovulation induction with IUI using clomiphene citrate was tried. The results showed that antioxidants did not improve the semen parameters or the DNA integrity, and the cumulative live birth did not differ at 6 months between the two groups. So they concluded that antioxidants do not improve the semen parameters or the DNA integrity, and the antioxidant does not improve in vivo pregnancy or live birth rates. So since my study also includes microfluidics, I want to present a systematic review and meta-analysis which compared microfluidics versus conventional techniques such as swim up and density gradient for sperm selection. 39 studies were included, and they found that microfluidics yielded sperms with lower DFI and increased progressive motility, total motility, and morphology. They also found significant differences in the fertilization rate, implantation rate, clinical pregnancy, ongoing pregnancy, and live birth rates. And there was no difference in the embryo euploidy or miscarriage rate. This study concluded that microfluidics may offer a beneficial approach in certain situations, particularly for patients with elevated DNA fragmentation. However, its integration into routine clinical practice cannot be justified yet in terms of cost effectiveness. So additional research is required, especially with respect to live birth rates, which remain the ultimate goal of any ART cycle. Thank you.
I would request our experts to opine about the presentation and ask any questions if any.
Anjali, it's a well presented and I mean, it's a good protocol you have presented. But I have a few queries. I mean, you're not looking at the DFI in your patients?
Yes, ma'am. Because of the financial constraints, since this is a DM thesis, I am not having enough grant for doing the DFI also. So that is why I had to skip that part, ma'am.
Okay, okay. Now, another thing I found in your study was the heterogeneity in the population you are going to take. You have to, what is the age group you are looking at? So, and also, what about, you'll have to see, one group might, even if you are randomized, there should be some age grouping in your protocol, because even if we say that male fertility lasts longer, but there can be age related decline, so you have to take that into consideration. So the another point I felt was that when you are matching your when you are looking at your population, you have to see how many patients, you are ruling out all medical disorders.
No, ma'am.
Okay. So what kind of lifestyle modification are you going to give?
Ma'am, I am advising in general diet modification and to improve the physical activity and also to restrain from substance use like alcohol and tobacco use.
So, what kind of alcohol restriction do you expect to give to? Yeah. So, what amount of alcohol and where you will start advising their modification?
Ma'am, I will first assess how much, like what is the quantity they are taking, and then I will encourage them to cut down to like no alcohol if possible. That is what I will advise, ma'am.
I don't think the guideline says that you have to advise no alcohol.
Yes,
So
ma'am.
alcohol, what is the moderate alcohol intake and what is the permissible? You have to look at that also. And if it is, because in today's world, you go and tell the male patient that you're not going to take alcohol, then probably they're not going to tell you. So these lifestyle modifications you have to take into consideration, and also the population, like the BMI distribution, that also you have to take. Okay, now tell me more about the microfluidics. You showed one study that would just give us the idea about the performance index. So I think Dr. Gaurav can talk about this.
Yeah.
But do you think our assessment can be based on microfluidics, the results? Dr. Gaurav.
So Anjali, I just want to first understand the rationale for using microfluidics. Just quickly, can you give the main rationale of why? Because you said, a couple of places you mentioned that semen analysis or semen parameters were assessed using standard semen analysis and microfluidics.
Yes, sir. Just before IVF, while we are collecting the sample, so we will also assess in the microfluidic sample.
Now, you
the
see,
sample.
microfluidics is a technique for selecting sperm.
Yes, sir.
But microfluidics cannot tell you if the DFI has, say, for example, reduced from 28% to 15%. It is not a test for assessing DFI levels or ROS levels, right?
Yes,
It
sir.
is a method for selecting sperm. So, it's not, it would not be just to say that you use microfluidics to assess a semen sample. You perform semen analysis. How you will assess the semen sample? Either you will do a ROS testing,
Yeah, exactly.
or you will do DFI testing.
Mm.
That you have a definitive objective marker that earlier ROS was high, and after giving antioxidants, it has become low. Or earlier DFI was high, and after giving antioxidants, it has become low. Now, I was just wondering, so see, this is, we are only trying to highlight that
Yes.
what we can learn from your study about research methodology, right?
Yes.
About study design. So, as far as microfluidics is concerned, I was thinking, so say you gave antioxidants to 100 people and it brought about an improvement, let's assume, in the semen parameters. You confirm that through semen analysis, where you saw better motility, better morphology, better progressive motility and counts. And 100 other people where you did not give antioxidants and then you assessed the sample. Here, right now, microfluidics has no role.
No, sir.
Microfluidics will not tell you that whether DFI has reduced or it has increased or there is any. Now, the change that you have brought about with the help of your intervention, actually through your ART cycle, when you apply microfluidics to both arms and you
Yes.
select out the best quality sperm with the lowest chance, because this is now, there is evidence that microfluidic will help you select the sperm with lowest DNA fragmentation and highest motility. So you have almost neutralized the difference of your intervention by using microfluidics, because you have chosen the best sperm in both the arms, and then you are going to test out the secondaries. Your all your secondary parameters are what all you said? Fertilization rate, blastulation rate, embryo quality, clinical pregnancy rate. So I was thinking that microfluidic, but I think you're using microfluidics as just a semen preparation technique, right?
Sperm for, yes, for IVF, prior to IVF, like fertilization, will be doing microfluidics in
Yes,
the arms.
yes. So you must think about this,
Yes, sir.
that using microfluidics may actually neutralize the difference
Mhm.
between both the arms,
Yes, sir.
where all your benefit through antioxidants is there, but even in the control arm where there are no antioxidants, still you are using a technique which will find those few best quality sperms, in your sample. And the second thing that madam was just saying, that if you use antioxidants and your inclusion criteria only included patients with male factor, right?
Sir.
All patients with male factor were included in the study. But how will you know if you see a improvement in your secondary outcomes? How will you know that that is only due to your antioxidants and not any other factor? There are so many other confounding variables like maternal age, ovarian reserve, number of eggs, maturity of eggs, uh, uh, the embryology lab parameters, the number of
Oh,
embryos
exactly
transferred.
what Dr. Gaurav you are saying. I mean, it would have been, I mean, if we are looking at the improvement, it would have been an ART before and ART after. So the same becoming a control. But here we are just giving treatment, and after that we are taking two groups and comparing. I mean, it's okay. That's our limitation.
Yeah, so what you just need to add one step in this, that you adjust for these confounders also.
Yes, sir.
Yes.
You adjust for age, you adjust for ovarian reserve, number of eggs, because these are known confounders of all the outcomes that you listed out. So
Okay.
that you are sure that if you see a benefit, then you have some confidence in stating that this benefit was due to antioxidants and not any other confounder. So
Yes.
it's a great idea to adjust for known confounders, and then your degree of confidence increases in your results.
Yes, sir.
Yeah.
Okay, another thing I want to ask is that I mean, you're thinking about the DNA fragmentation, but the CoQ dose, urobiquinol dose, that seems a little, I mean, it's only 100 milligrams twice a day.
Yes, sir.
So that dose seems a little lesser. I mean, if you are thinking that improvement of DNA fragmentation would occur, then the advised dose is much higher than this. So, apart from the L-carnitine, which would do the benefit, but the dose maybe you can, if you can, your protocol must be submitted, but you can just add on to that.
Okay, ma'am.
Yeah.
I have one more point, Anjali.
Yes, sir.
Your trial is open label,
Yes, sir.
and your primary outcomes are motility assessment, morphology assessment, uh, which are observer dependent,
Yes, sir.
right? So don't you think it would be better to blind the outcome assessor, the person who is doing the semen analysis, to treatment allocation? Because
Yeah, I think that's an excellent idea.
to reduce observer bias.
Yes, that's an
If,
excellent idea.
if I know that someone has got antioxidants for 3 months, then it may affect, it may bring in a bias. So it is important to know that even with open label trials, you can blind the assessor, because obviously it's hard to blind the participant, because one is getting antioxidant, the other is not getting antioxidant. This is not a placebo trial. But you can, because the outcome is not an objective outcome. It depends, there's a lot of variation in assessment. So you can think about that.
Yes.
Another thing, Anjali, did you, I just want to know regarding your primary outcome, that since you are using antioxidants prior to ART cycle with the aim of achieving a benefit in ART outcomes, did you not think of using the ART outcomes as the primary outcome instead of the improvement in semen analysis?
Yes, ma'am, initially, but then the sample size was going very high if I wanted to show an increase in clinical
Because
pregnancy rate.
this
And I had
sample,
time constraints within 2 years.
this sample size is actually inadequate for your secondary outcomes. It is highly inadequate to look at clinical pregnancy rate, but still to look at semen parameters, it may suffice.
Yes, sir.
And how much, compliance issue do you expect in your?
Ma'am, mostly whatever I have seen patients, usually they are compliant, but now I have to actually assess whether they will bring, once they bring me back the packets, whether it is 100% or not. But from what I have talked to the patients prior, they have told they have followed it correctly.
Okay. So you can probably give them an appointment. So
yes, ma'am.
ART date, so probably that will leave them compliant.
Yes, ma'am.
Right, great. I think that should be all.
Thank you, sir.
Yeah. Best of luck with your study.
Thank you, sir. Thank you, ma'am.
So here we end our session 1 for today's talk. I would like to thank our chairpersons, experts, and the presenters for such insightful talk. Now we'll move forward with our second session. I would like to invite our chairpersons for our second session. So I would like to invite Dr. Sangeeta Chaudhary. She is Vice Chairperson and Senior Consultant, Department of Biotechnology and Research, Sir Gangaram Hospital, Academy Fellow, Fellow of Association of Researchers and Academics in India. Our next chairperson is Dr. Sabina Singh. She is Senior IVF Consultant in Akanksha IVF Center. I would invite you both, ma'am, to introduce Dr. Ruma Satvik for the next discussion.
Can you hear me? Hello?
Yes, ma'am, you're audible.
Yeah. I think everybody knows on this forum Dr. Roma Satvik. So we can start straight away with our talk.
Yeah. Should I share my slides?
Yeah.
All right. All right. See, I know, I mean, research is something which is usually low down on people's priority, but and especially statistics, because you always have a statistician in your institute or around you who can do this for you. But believe me, understanding some basic, ideas or concepts around what you're going to be using, the data, how you present it, and what are the statistical testing, allows you to understand the paper a lot better and maybe even critique it, whether this data that you're seeing in the paper, could it be true, or do you think it is fabricated, right? So as you reviewers, at some point, you all graduate, you get papers to review, you get an idea on how to sort of get an idea on whether this data could be real or fabricated. So we have a very sort of basic talk on what data can look like, clinical data, how you present it, and what are the tests you need for data comparison. So understand that there are two primary kinds of data types. One is categorical, also called qualitative, but let's stick to the word categorical because it defines categories. It could be two categories, in which case it's called binary. It could be four categories, which is multi-categorical. The other kind is the numerical kind of data, which is a continuous data where it takes, figures, integers, anywhere from 0 to infinity. So that is your numerical data. Now, categorical data is divided into two kinds, nominal and ordinal. Nominal data in your discipline would correspond to something like what is the cause of infertility, and you know that you can broadly categorize them into male, female combined or others. It could be that, or within the female category, you can divide it into tubal, ovulatory, unexplained, endometriosis, and others. So when you give a name to a category, it becomes nominal data, and there is no particular order to it. Order as in azoospermia could be number 1 cause or number 5 cause. It doesn't really matter how you are putting it out there. It could, for all you know, be in alphabetical order. Ordinal data is, again, you have a name to the categories. These are still categories, but the second one following the first is a natural order. So nullipara, primipara, multipara, okay, is a kind of categorical data that you put in the category of ordinal data. What about numerical? It is not, so we don't really go into the details of this, but there's something known as an interval data and there's something known as continuous data. Intervals are what you define. So you could define age groups as 25 to 30, 35 to 40, or there is like a continuous age data where you say, I'm going to take it to the nearest completed year. So 5, 10, whatever, 1, 2. So in your situation, in the situation of infertility studies, it could vary anywhere from 23 to 50. Right. So an example of interval data could be age in years presented as in intervals or in categories of so short, repetitive categories of 2 years or 5 years. And continuous data looks like age presented not in categories, but as the actual value where it is, or AMH, the actual value where it is. Now, we just coming quickly to numerical data, you have two kinds of numerical data. One is normally distributed data, and the other is the one that has skewed distribution. Why is it important to know all this? Because based on this, you use your presentation methods and you use your statistical tests. So what is normal data? You all know this. You've probably been reading it since class 10. This is what it looks like, literally like a bell curve. There is a peak right in the middle, and then there has two tails, one on the right and one on the left. And there is equal distance between the peak and the tail on the right and the left. So what is this denoting? The peak is denoting where the maximum number of people in this population lie. So let's say this was an age distribution of women with infertility. And when I use the word infertility, it would obviously be a skewed data, but let us use something else like the age distribution of women in your locality, that is likely to be a normally distributed data. So there will be one age year or one value where most women kind of lie. So let's say that is the age of 32 to 35, and you'll find that most women are there. But then there are women on the left and the right, and they're equally distributed, older women and younger women in the middle, from the middle point, right? So this spread, how many women lie on the right and how many women lie on the left, is denoted, you use the word variance or the word standard deviation. And so for any continuous, normally distributed data, if you had to represent it, you always present it by the middle value and how much it is deviating to the left and right by using the terminology standard deviation. I'll come to the mathematical formula in just a while. You don't have to memorize that, but just know where you are using all of this. So there is another bit of statistics which is always true with normally distributed data, and that is that 68% of your sample lies within one standard deviation of the mean being the peak value, and standard deviation being a value which is how much away from the mean it is. It generally represents that, but I'll give you the mathematical formula in just a bit. And 95% of the sample lies within 2 SDs of mean. So when you represent a numerical data, you put the mean there, and then, which is normally distributed, and then within the bracket, you do an SD. So plus minus this much, 2 SD. So what would the range look like from the 5th to the 95th centile, right? So you've pretty much understood this. What is skewed data? Now, this is how it looks. It's not a proper bell curve like in the middle. You could have the peak value lying a little more to the right, or you could have the peak value lying a little more to the left. When the tail is in the negative direction, in the smaller direction, you call it a negative skew. And when the tail is in a positive direction, you call it a positive skew. Now, remember that most trials that we do, or most studies that we deal with, and the data that we deal with, age is likely to be a skewed data, though on its own, biologically, it's a normally distributed data. But because we put limits at who can enter IVF and who cannot, it is likely to be a skewed data. What is the kind of population your center entertains? Is it more women with sort of elderly age, so women closer to 35, 40, 45, your median? And so then you have a more negative skew data if you have more older women. But if you have more younger women coming to you, you have a more positively skewed data, right? How do you know if your data is normal or skewed? So you've done your study, you've collected your data, you have your age in one column, you have your AMH in one column. There are all these softwares like the SPSS, which most of you tend to rely on, that will do this job for you. That will, if you were to sort of just go there into the data types and check distribution, it will tell you either draw out that distribution, or it will give you a skewness coefficient, which again, you don't have to learn, but understand what this means. That skewness coefficient more than 1 or less than -1, you know that this is a skewed data, right? Again, why do we need to know that this is normal or continuous or categorical? Because this is where it will matter, data presentation, and this is different for different data types, right? We come back to our original, the first slide on categorical variables, nominal. So infertility type, primary or secondary. So if that is what you were looking at, those are the only 2 types of infertility. Or you could also have secondary with previous live birth or secondary with no previous live births. So here you will look at a number count. So nominal data or ordinal data can be counted. How many numbers of primary infertility were there? So you represent it as frequency. So let's say in a data of 100, you found 60 women with primary infertility, which constituted a percentage of 60%. This came to a ratio of 6/10, which is so basically you have to have a denominator of 1, so 0.6 by 1, and proportion again becomes 0.6, and rate is You want to know how this proportion or this frequency or this percentage is changing with time. When you put a time variable there, it becomes rate. So in true statistical sense, rate has to have a time parameter in its denominator, right? What about numerical variables? Well, I just told you about distribution curves, the normal curves or the skewed curves. You could also do it in histograms when you have interval data. And when you are doing either, you have to have a central value, which is either a mean, median, mode, and a variance value, which is a range standard deviation, right? So I'm going to give you an example of categorical data, right? We are going back to parity example where, in this, we will also see how that is changing with time. So in the year 2009, let's say at an IVF center, the women who were primiparous, which is sort of nulliparous, never conceived in the past, constituted 679 women, and the ones who had been pregnant at least once were 291 of a total of 970. And similarly, 10 years later, you see there have been some changes in number. This is not making any sense. You don't know what is really happening unless you use some outcome variables like a proportion, which express part of a whole as number or percentage. So in this case, in the year 2009, the proportion looks for nulliparity, it's 0.7, and for 2019, it is 0.6. So it immediately gives you, because the denominator has now been neutralized to 1, it gives you an idea on how things have changed in the past. Ratio will compare two quantities. So you could do a nulliparous to multiparous ratio. So in this case, you are doing in 2009, nullipara to multipara 679, 291, it's 2.3 to 1. So for every multiparous woman who presented for IVF at a certain center, there would be 2.3 previously, 2.3 nulliparous women. And that ratio changed with time from 2.3 in 1 to 1.5 in 1, right? What is the rate? It is the change in quantity with time or intervention used for outcome data. So not only that, you understand that women who have conceived in the past are now constituting a greater chunk of population who are coming to you, and that constitutes maybe about a 14.3% increase in the chunk of multiparous women, or a 14.3% decrease in the chunk of. So this is just a random example to illustrate how you use proportion, ratio, rate in cases of categorical data, right? And then you have the frequency table, which represents this data, which is just a count of a certain event that is happening, right? So numerical data, I talked about histograms, and you have all used it, where you have frequency on the y-axis and the variable that you're representing, in this case, age, in the x-axis. Now, while this seems like it might be a completely skewed data, I would want to put this through the software to see if this was skewed or normally distributed, because sometimes even with something like this, it will state that the skewness quotient is less than +1 or within the range of -1 to 1 +1. And so you could still treat it as normally distributed data, right? Now, whatever you may have, either a histogram or a Bell's curve, whatever you are sort of able to produce on the software, the thing has to be represented by a measure of central tendency, which is either the mean, median, mode. In a normally distributed data, it corresponds, all three are similar, are the same value. But in a skewed data, you can see that the three values will differ. And this is what is the larger point of why we are doing this, one of the points on why we are doing this presentation, right? Apart from the central sort of tendency measure, you also have to have some measure of knowing how widely the data is distributed, and this is known as measures of dispersion. So let's quickly look at an example of mean median mode through goals scored by this particular football player in the last 7 games. So let's say in game 1 he gets 1, 3, in the next 4, 6, 6, 7, 8, and these have been arranged in the ascending order. So mean here would be a sum of all of those divided by the total number of observations. We already know this. Median is the central value in this ascending order. It comes to position 4 from the left or position 4 from the right. And that's 6. And mode is the most commonly occurring value, which is 6. Now, in studies that we do clinically, we either use mean for normally distributed data, but we use median for skewed data. The other thing that you can still do for skewed data, because most data is skewed, you can present it in range, which is a measure of dispersion from the smallest value to the largest value. You could do an interquartile range. This is the most commonly used dispersion measure for non-normally distributed data, which is all the values have been arranged from the smallest to the largest. The value which is on the 25th centile. So if you have 100 values, the 25th value to the 75th value. So in this case, the interquartile range becomes 3 to 7, right? And the midpoint is 5. So 5 with an interquartile range of 3 to 7. Variance is, so earlier it's an easy concept to grasp. So you are basically seeing how much each value moves away from the mean. So you could simply subtract the primary value from the mean and say, okay, this was 3 points away or this was 4 points away. Except that when you add the right values to the left values, you get a big zero under, especially in normally distributed variables. So what would you want to do instead? To avoid that zero, you square it, you sum it. Now you divide it by your total observations and you get your variance, right? Standard deviation is just to sort of say, what is that distance? You do a root of that variance and you get standard deviation, right? So we present our data for a normally distributed data with mean and standard deviation. And for a non-Gaussian distribution, also called as non-normally distributed data, with median and interquartile range. Now, this is how you represent your median and interquartile range, right? If you had to draw a kind of a representative figure, it looks like this, and it's called a box whisker plot. It literally defines what is contained in the figure. So a box is this and whiskers are this, right? Whiskers are these. So here we are looking at 3 categories of patients. This is a study that I had done. It was a cohort study looking at vaccine status at OCR, whether it affected live births or not, right? So that is what the study was. It got published in 2022. But the data was collected in the peak of COVID, and there were 3 categories of patients: women who hadn't received any dose, there were women who had received 1 dose, and there were women who had received 2 doses. This, of course, represents a continuous variable. How was AMH distributed in these women? And this was to say that their medians were slightly, if you can see, only marginally. So what represents what in a box whisker? I'll quickly say the central line represents median. The top line of the box and the bottom line represent the 25th and 75th centiles. And the top whisker, which is the thing at the top, is the 95th centile. The bottom is the 5th centile. And what you see outside that are called outliers. And as it happens, there are a lot of outliers. So this is a hugely skewed data and best represented through this. And it pretty much represents the distribution of AMH in the 3 category of women. And the test that was used was independent samples, Kruskal-Wallis test, and it said it is equal or equivalent, not significantly different in the 3 groups, right? So this brings us to data comparison, the last part of this talk. So you have most studies which are trying to answer a question of intervention, right? So in the first talk you heard whether treatment A is better than treatment B in a certain group of patient. And and how will you know? Not just by primary results, like for instance, in the paper that was presented just a short while back, what I thought was not defined, or maybe I missed it, was how do you really define an improvement? Because sperm parameter or count or motility is a continuous variable. You could have a 15 million changing to 18 million, or motility changing from 22 to 25. Does the researcher feel this is significant change, or does the researcher feel this is not significant change? But that is just my input on the study. So here we are trying to say that because you have two groups, you will have to compare the results. And the results are what tests you apply. You need to know what the type of sample is, what the type of test is, whether there are two groups or more than two groups you are comparing. And lastly, what is the type of data, categorical or normal or skewed? So when I talk about type of samples, I'm mentioning independent versus dependent. So again, in the previous study, which was on use of antioxidant in men to see how the sperm parameter were changing before and after. Of course, there are two groups that the researcher has made. One is the one that is receiving antioxidants and the other that is not receiving antioxidants. But you could also see it as a before-after that was being said. So a before-after is being done in the same individual. What the parameters look like before the intervention and what the parameters look like after the intervention. Such samples are called dependent or paired samples, where the controls are selves. Okay, even in Dr. Modi's talk, you heard how the same individual works as control, over a period of time, because the same individual has been given drug 1, washout, drug 2, washout, drug 3, washout, and back to drug 1. So it's the same individual. And so here, most of your confounders are sort of contained and they are similar. So in a dependent sample, you will have also called paired samples. You use a paired t-test, as I'll explain in the next slide. But in an independent sample, where you have one set of people receiving a treatment and the other set not receiving a treatment, and they are not linked in any other way, except for the fact that they are matched by some of the confounders, they are called independent samples, right? So tests for comparison of means, normal data and skewed data, different tests, right? Normal data, two groups and a dependent sample, you use a paired t-test. Now that is a very commonly used test. Remember, this is ideally done for a paired t-test. And for independent samples, two groups, you do what is known as independent samples t-test. It's just something which statisticians know how to handle, because not using the right test might overestimate the effect or underestimate the effect, right? So your probability of a difference existing can either go up or it can come down based on what you are using. And this may not have anything to do with what the actual results were like. Just incorrectly selected tests. For more than two groups, normal data, you use one-way ANOVA. Skewed data, two groups, again, you use these words very commonly: dependent sample, Wilcoxon rank sum test; independent sample, Mann-Whitney U test; more than two groups, Kruskal-Wallis H test, just the way I showed it to you in the previous slide. Also, you could be correlating. One is comparison, the other is correlation. So correlation can be between two normally distributed variables, like age in a population, AMH in a population, biological population, not your infertility population. And then you use Pearson's correlation coefficient. But in the real world, you don't really get a normally distributed data. You have skewed data. And so you use Spearman's correlation coefficient. Once again, knowing the right test here accurately estimates whether there is a true difference or not, right? So here the results are expressed in R. You will have a value which is a full negative sort of selection. So it looks like this, right? A negative sort of a 45-degree going down. That's a -1 correlation. Or you have a 45-degree going up. That's a full correlation, that for every 1 unit change in variable 1, there is a 1 unit change in variable 2. So the R can vary anywhere from -1 to 1. Remember, in studies, again, nothing is so perfect. You're looking at R values of more than 0.3, and anything more than 0.3 can be, say, okay, modestly correlated, right? What happens when you have to correlate a binary variable with a continuous variable, like poor response in IVF after stimulation, after COS, with AMH. Let's say you wanted to do that, AMH, which is otherwise a continuous variable, and poor response, which is a yes or a no answer. So more than 3 oocytes or less than 3 oocytes, you can make it a binary outcome, yes, no answer. Then you use what is known as receiver operating curves, right? And it is expressed as, the results are expressed as AUC. Again, the value can vary from 0 to 1. Remember, you are trying to be as close to 1 or as close to 0. Anything close to 0.5 is a line of no difference, right? Lastly, categorical data comparison is you use chi-squared tests, Pearson's for large samples, Fisher's for small samples, using the right test. And I'm not going to tire of saying this, is necessary to get the right statistical significance test. All of this is to calculate your P. What exactly is P, right? Overused and abused, I feel. But we are going to talk about its interpretations and limitations. P-value is the probability that difference between test and reference samples, so drug A versus drug B, 2 samples, is due to chance. Remember, and what is chance? Why are we even assuming there can be chance? And why can't we just believe that one drug treated 40% of patients and the other treated, sorry, my hair got trapped, and the other gave an outcome in 50%? Why are we not happy with that? Just say that there is a 10% difference and get done with it. No, why are you talking of chance? The answer is that if you repeated the same experiment in a different set of population, or if you did it, let's say, in the US versus in India versus in Australia or Madagascar, uh, because of the population, because of observer bias, because of methodological differences, the results can be going all over the place. So that 10% positive 10% difference can be seen in one set of study, but the other one is saying a -10 difference. There is a third one saying a -5 difference, and the fourth one is saying, okay, this is a +5. So eventually it all just evens out. So in your study, always remember as a researcher that there is a huge possibility of chance causing this, right? Because you have only tested a small sample, which is just a tiny droplet in the ocean, which you are doing, and this could well be a result of chance. So the p-value is saying whether the probability of this result happening due to chance is less than 5% or not, right? And it is not still. So it might say it is 0.04. So there's a 4% chance that this difference is existing because of chance. There's a 4% probability that this difference has become existing because of chance. However, why is p-value not enough? Because a lot of people try to work towards 0.05, less than 0.05. And because of that, a lot of data can be fabricated, but that's not enough. You want to, so for a clinically meaningful result to be seen, you need something known as effect size. And what is effect size? It is again talking about how much is the difference. Not just that the probability is less than 0.05, but how much does it really vary, right? So if you had a categorical data like live birth, which is what we are working towards, you would want to do an odds ratio that the live birth rate in without intervention was this, and live birth rate with intervention was this. So you can calculate these 3 things, and it gives you some idea about how much that difference is: odds ratio, relative risk, and risk difference. And for a numerical data, you try and say that my sperm parameter changed by 5 million per ml, a positive change in 3 months of use. And so when you're saying that this is your mean difference, standardized mean difference is how much away from the standard deviation your results are. So just to quickly end this with and explain odds and odds ratio to you, and we will be doing a separate class on odds ratios, risks and relative risk, because that again is an overused, abused term in our discipline. Odds is the chance of an outcome occurring versus not occurring, right? So it's not really the same as saying, okay, my live births improved by 20% when I did this. It is saying that the odds of live birth improved by 20%. And you will understand this when I give you how these are calculated. Odds ratio is ratio of odds of an outcome occurring with exposure to odds of an outcome occurring. It will still occur, but without an exposure. And so let's say this was an example in non-male factor infertility. This is a published paper and I've just picked it up from there. Non-male factor infertility, whether ICSI helps more than IVF in improving live births. Okay, again, you can see this is a frequency distribution. Live birth is a categorical variable. No live birth is a categorical variable. Automatically follows live birth. Total population minus live birth is no live birth, right? So ICSI, you see the frequency 400 and no live birth 620. Non-ICSI, you see the frequency 450 and 540. And then you see the total numbers, right? Odds is, again, coming back to odds of an event, outcome occurring. So odds is chance of an outcome, 400 divided by 620 upon 450 divided by 540. So AB upon CD. You've all probably done this, but understand, just to put things in perspective, I'm just explaining this to you. So here the odds come to 0.77. What does this mean? This means that if you used an ICSI, your odds of, in a non-male factor infertility, you would have a reduction in the odds of live births by 23%, which is not the same as saying that actually it will reduce and for that you need relative risk. I hope I have the relative risk example as well. Yeah, the same one, the same slide. So what is relative risk? And this is more intuitive. You understand relative risks better than you understand odds ratio. So wherever you can use relative risk, use absolute risk difference and stuff like that. So what is this? This uses denominator as the total population. So live births in ICSI divided by total women subjected to ICSI upon live births in non-ICSI upon total women subjected to non-ICSI. So what is the chance here? 47% you had in the unexposed group, 47% live births in the non-ICSI group, and 39% in the exposed group. Now this we understand a little more intuitively, slightly better. So you would say there is an 8% reduction in your live births if you used ICSI in male factor, in non-male factor from the baseline of 39, from the baseline of 47%, right? Or you could also say that the risk ratio drops by 17%, or the relative risk comes down by 17%. Relative risk of live birth comes down by 17% if you used ICSI in non-male factor versus IVF. All right. So confidence interval is a measure of precision. You, apart from using odds ratios and your relative risk, you always see that bracket next to it. That is the confidence interval. Again, odds ratio is defining how much, or relative risk is defining how much that difference is by. But the confidence interval is defining that if you repeated this experiment 100 times, where would the result actually lie, right? So confidence level that denotes probability of the point estimate lying within that stated interval. For ratios, line of no difference is 1, and for means, lines of no difference is 0. Narrow confidence intervals denote large sample sizes, greater precision, right? So You could use your chi-squared test in that example and it would say it is significantly different, but your odds ratio denote how significantly different this was, right? I think I'll end this with the fact that you all need to do your research. First of all, understand your sample, know the kind of data you're collecting, know your own objective, and based on that, present it to the statistician and she or he can do the rest. But also know how to represent this data figuratively, know the groups being compared, apply appropriate tests, determine effect size and confidence intervals, because that is what is speaking to a clinician much more or the researcher much more than just your significance levels. Thank you.
Thank you so much, ma'am. It was very informative, ma'am. And you started with the basic concepts and covered also most of the doubts got cleared today.
Right. Good. I'm glad. Thank
I
you for
just
that.
wanted you to highlight, ma'am, that between odds ratio and relative risk, which is better for depicting
Yeah,
this?
so there was a slide, but I thought it's exceeding time so much. Odds ratio is you can't do relative risk in all studies. So for all retrospective study designs, it cannot be anything other than odds. For a case control design, it cannot be anything other than odds. Remember, relative risk uses total population. So the starting point is the unexposed women or the exposed women. Your outcomes have not yet happened. So for all prospective studies, either an RCT or a prospective cohort, you can calculate relative risks. Relative risk is, like I said, an immediately understandable figure. In the example you saw, it showed a 17% reduction from baseline, which is a relative risk reduction, or an 8% absolute risk reduction. So from baseline minus 8%. So you understand this directly. But when you use the word odds, which is again has its limitations, but it has its place also, because in retrospective study designs, you can't do anything else. You would, because it is using outcomes that have happened and not happened, right? So case control or all retrospective designs, odds ratios work. You can't make too much sense of that. You saw odds ratio was artificially inflated to, what was the figure I had said? Odds was much higher, 23%, right? 23% reduction in odds of live birth, which is not the same as a 17% reduction in the relative risk of live birth. So we will have a class on this because it's a very important concept for all of you. We'll also talk about adjustment. We'll talk about other things, probably 2 months from now. But yeah, it is an important concept and we'll deal with it.
That was very nicely said. I hope many of the medical students did understand it. One question that I don't know if I've missed it was, how does the missing data impact? Because I think, did you say anything about it?
Missing,
you mentioned about the screw data, that was the box whisker. Did you say anything about the missing data?
So what is missing from this talk are many concepts. One is that there is also a time variable, something which is known as, time to event variable. I haven't spoken about that because I thought it would be too much for the class. I was just trying to deal with what these guys deal with. So cancer studies will have time to event variables also that you do through Kaplan-Meier analysis. The numbers living or the numbers dead after a certain number of years of use of chemotherapy or something like that. So, or even other people who follow up long-term data, you use time to event variable. But that's a different talk. Again, we can talk about it. Missing data comes in when you're dealing with retrospective studies. Again, separate talk, but we can talk about how much. There are different ways of looking at missing data. If it is important to you, you will have to address it. One is that if more than 50% of your values are missing, you just can't use that variable at all. But if 5% of your variables are missing, it's all right. You can still calculate your mean. There is a cutoff for how much is allowed, where you can still do your mean calculation or your categorical variable calculation. And then there's something known as imputation, where you kind of do a closest approximation to mean, which is again a software thing, again for a limited number of values. So if you have a larger part of your data missing, you cannot use that data where you say, or then you'll have to reduce your sample size to where that data is available. So missing
Or
data
remove
is
those parameters. Or remove those parameters where you have that many, especially in follow-up studies.
Follow-up studies, of course. Yeah.
Thank you, ma'am. Now, moving on, Kajal, if you could invite
Yeah, ma'am.
our
So,
next
our next fellow paper presenter is Dr. Simran Vora. She is F&B Reproductive Medicine at Gangaram Hospital. I would request Dr. Simran to share her slides. Till then, I'll introduce to our speakers and experts for this. So our expert is Dr. Ruma Satvik. She is Deputy Director, Senior Consultant Professor at the Gangaram Hospital. I would like to introduce Dr. Garima Kapoor, MBBS MD, Professor at BMMC and Safdarjung Hospital, National NBMS Webinar Coordinator and Joint Editor at IFS 2026 to 2028. And I would like to introduce you to Dr. Archana Kumari. She is Associate Professor, Department of Obstetrics and Gynecology at AIIMS, New Delhi, currently pursuing DM in Reproductive Medicine and Surgery, AIIMS, New Delhi. Welcome to everyone. Dr. Simran, you can start your presentation.
Is my screen shared? Everybody's...
You're audible and your screen is shared.
Okay. Good evening, everyone. I am Dr. Simran and I'll be presenting my protocol, which is for the research project. So the title of my study is Physiological Intracytoplasmic Sperm Injection for Improving IVF Outcomes in Couples with Advanced Paternal Age, an Ambidextrous Cohort Study. So we keep talking about the maternal age and decreasing ovarian reserve. However, we know that male factors also contribute to 35% of the infertile populations. So besides just looking at the semen analysis, there is evidence that established that pregnancy rate decreases and time to conception increases as the male partner age increases. And in today's world, it is very relevant because an increasing number of men are choosing to father children at older ages. So the definition in our study is male age more than equal to 40 years. It is defined by AUA and ASRM guideline. So that cutoff is established. However, there is no universally accepted cutoff for this age group. So we know that advanced paternal age has a lot of impact on sperm and reproductive outcomes, coming to increased oxidative stress, which may be due to increased ROS production and also decreasing the antioxidant defense. It can also lead to increased DNA fragmentation, increased sperm aneuploidy, which may lead to embryo developmental errors and consequences in reproduction, which will be poor embryo quality, reduced implantation and pregnancy rates, higher miscarriage rates, and increased risk of genetic disorders in the offsprings. So this is the largest meta-analysis which was produced for this age group, in which we can see that comparison was done for pregnancy rates in less than 40 years and more than 40 years. And we can clearly see that the odds ratio was 1.65, which clearly indicated that increasing paternal age has effect on clinical pregnancy rate and miscarriage rate. So we have established the fact that advanced paternal age has an impact on the reproductive outcomes. So now how to select the best sperm so that we get better outcomes. So initially we used conventional ICSI, which chose the sperm based on morphology and motility. But we could not assess DNA integrity and chromatin packaging. Then came IMSI, which is intracytoplasmic morphologically selected sperm injection, which is also assessing the morphology of sperm, but at a higher magnification. It can detect subtle defects, but still DNA integrity was missing. Then came MAX, which is magnetic activated cell sorting, which provided selection based on a biological cellular marker, which was annexin 5. But still, only apoptosis associated changes were assessed. And then came PIXI and microfluidics. So my study is basically on PIXI. We know that PIXI uses hyaluronic acid binding as a criteria for sperm selection. We believe that the sperm, which is more mature and functionally competent, binds to the hyaluronic acid, and it is a physiological criteria than just conventional morphology and motility, which was initially used in ICSI. So we know how PIXI is being done. We choose the sperm which is immotile, like this sperm, on the PIXI media, and we choose the sperm, and then we do the ICSI. So this is the HAB Select trial, which is the largest randomized control trial. It was done in Europe in 2019. It compared PIXI with conventional ICSI, although their primary outcome was live birth rate, which came out to be not statistically significant. But we can clearly see that the miscarriage rate in this group came out to be statistically significant and was lower in the PIXI group, which is the assumed analysis of our study as well. So coming to my study, the aim of my study is to compare embryological and clinical outcomes with and without PIXI in couples with advanced paternal age more than equal to 40 years. The objective will be to compare embryological and clinical outcomes in couples with advanced paternal age who are undergoing advanced sperm selection with PIXI versus matched controls not undergoing PIXI. The study will be performed at Center of IVF and Human Reproduction at Sir Gangaram Hospital. It is an ambispective cohort study. There will be prospective as well as a retrospective arm. The study population will include couples undergoing ART with self-sperm from the male partner age more than equal to 40 years. We'll include all couples undergoing ART for any indication using autologous self-oocytes from the female partner, as well as for any indication using donor oocytes. And our exclusion criteria will be surgically retrieved sperms, donor sperms, large adenomyotic uterus, unclipped hydrosalpinx, intrauterine adhesions, submucosal fibroids, and intramural fibroids which are more than 4 centimeters. So there will be two cohorts. One will be the PIXI group, which will include couples with female age 23 to 44 years who are undergoing PIXI with self or donor oocytes. And the second will be conventional IVF and ICSI group, which will be female age and source of oocyte matched couples undergoing conventional IVF and ICSI. Our primary outcome is clinical pregnancy rate, and secondary outcomes are fertilization rate, blastocyst development rate, beta HCG positivity rate, implantation rate, miscarriage rate, and ongoing pregnancy rate. So clinical pregnancy, it will be defined as intrauterine gestational sacs with a cardiac activity, which will be seen on transvaginal ultrasound done at 6 to 7 weeks of gestation. And the rate will be number of clinical pregnancies divided by total number of embryo transfer cycles. Fertilization will be assessed accordingly for conventional IVF and ICSI. And it will be number of oocytes with 2PN and 2 polar bodies with number of metaphase 2 oocytes injected in the ICSI group and number of oocytes chosen in the IVF group. Cleavage will be assessed on day 3 after fertilization, and it will be number of cleaved embryos divided by number of 2PNs. Blastocyst will be assessed on day 5 and day 6, and it will be number of blastocysts formed divided by number of normally fertilized oocyte, which is 2PN. Implantation will be assessed both on cleavage stage and blastocyst stage as we are taking both day 3 and day 5 embryos. And it will be number of gestational sac visualized on ultrasound divided by number of cleavage stage embryos transferred or blastocyst transferred. Beta HCG positive will be taken as more than 25 milli international units after of day 11 after day 5 embryo transfer and 14 days after day 3 embryo transfer, and number of positive pregnancy tests divided by total number of embryo transfer cycles will be taken. Miscarriage rate, miscarriage will be defined as any pregnancy loss which will be occurring from positive beta HCG till 12 weeks of gestation. It will include the biochemical pregnancy loss, embryonic loss, and missed abortion, and will be number of miscarriages divided by total number of positive pregnancies. And ongoing pregnancies will be all pregnancies which will be continued beyond 12 weeks of gestation, and it will be number of ongoing pregnancies divided by total number of embryo transfer cycles. So this is my study flow chart. We'll screen all the couples who are undergoing ART at our center and assess them for eligibility according to the predefined inclusion and exclusion criteria. So couples who will be fulfilling the inclusion criteria, they'll be considered for the study. And as this is an ambidextrous cohort study, the participants will be included, will come from both the retrospective and prospective arm. The retrospective arm will include patients from the predefined study period, and the prospective arm will include participants after obtaining ethical clearance and consent. And both the arms will be included in the final analysis. And based on the sperm selection strategy, which will be decided based on patient, clinician, and embryologist decision, participants will be categorized into two cohorts. First will be the PIXI group, and second will be the control group, which will be female age and source of oocyte matched. And both we'll follow both the groups, and further statistical comparison will be done between both the groups. We came to this sample size as I already defined this largest study trial, in which although their clinical pregnancy rate was 35%, so we assumed an absolute difference to be taken of 10% to be clinically meaningful, and with alpha of 0.05 and power of 80%, our sample size came to be 750, and accounting for 10% attrition, it came to be 830 participants. But this study is of fixed duration, and if this target sample size is not achieved, we'll take all eligible consenting couples during the study period, and we'll acknowledge this as a limitation during interpretation of the results. So this is how my results will look. We'll see these are my clinical outcomes. We'll calculate the odds ratio with 95%, and these are my embryological outcomes. Thank you.
Yes, Simran. Am I audible?
Yes, ma'am.
Yeah. So very nicely presented. I have certain questions for you, Simran. Is it fine?
Yes, ma'am.
So my first question to you is, why did you choose it to be a simple observational study type? You have mentioned that it is an ambidextrous study.
Mm-hmm.
Okay, so if we have to compare PIXI with ICSI, wouldn't an RCT would have been better?
Yes, ma'am, but the study I am here for another 1 year. So conducting an RCT in this study duration, like till now, we have around 50 to 60 samples which have been done for PIXI. So we were not able to achieve the sample size which was required for an RCT. So we are taking it as a ambidextrous and a retrospective, prospective study.
Okay. So for any study which compares, ideally it should be an RCT for such outcomes. Okay. And
Yes.
you have mentioned in your your inclusion criteria that you will be doing matching of female age and the oocyte source.
Yes, ma'am, because
Isn't it?
yes, ma'am. Because in this age group, like we are taking
So
more than 40 years paternal age, so they will be mostly the females will be female will not be included, and they'll account for donors. So we'll match the donor with the donor, and if the female is a self oocyte, then we'll match their ages.
No, but then what about other variables? Like what about BMI could vary, the ovarian reserve could vary between the two groups, the AMH, the semen parameters itself. What about the semen parameters? They could vary in between the two groups, even in even in men who are more than 40 years of age. So, and even the sperm DNA fragmentation. So, how will you account for these confounding variables if you do not include these into your study for matching in between the two groups?
Yes, ma'am, we will match for groups which have oats, which have semen abnormalities, but there will be confounding variables.
Okay, okay.
So I think the suggestion, Simran, is that there will be many, and it has been said in the previous presentation also, that all researchers who are looking into questions of intervention have to ideally plan an RCT. Because RCT requires, and especially here, there is an intervention. This is a private hospital. There are costs involved.
Dr. Ruma, your voice is low. It's not
Sorry.
audible. Yeah. Yeah.
Right. Better? Yeah. No,
Yeah.
this is just for the sake of the audience also, because these are valid questions, okay? The question that why are you not planning an RCT is a very valid question. For a question of intervention, a clinical question of intervention, ideally it should have been an RCT. It also has outcomes that you can measure in short term, not like, outcomes that will happen 10 years or 20 years later, right? So RCTs, the biggest limitation, as you learned from the first talk, is its feasibility. It's sort of need to clean up populations of every little difference that they have. You can, of course, randomize as much as possible, but to keep the population as homogeneous as possible for the sake of the study. So, here you have that limitation of time. You have to try and finish this in a year's time. And you know that there is data lying from the past 3 years, and then there's data that you can collect in the 1 year, and you will probably have a substantial thing. But even when you do all this, you will have all the data. There will be limitations of how your groups were not matched. Your intervention group and the other group were not matched, right? And this, you as a researcher have to know this. And how do you address it in an observational study? There will always be limitations. And in, again, the previous presentation, you were told about you collect all the data, including semen analysis parameters. You categorize them into normal, low count, low motility, low whatever. You collect BMI data, and then see if you can do, if your numbers are so much, if they're huge, like, thousands or 2000s, there are different matching methods. One of the matching methods is what is known as propensity score matching, where you have your intervention group, maybe 300. Control group can be as high as 5,000 or whatever. It could be from wherever. But you match them based on at least three very important parameters. Female, the ones that can most likely affect and have a bigger effect size on live births. Age is one, right? BMI may or may not, but then the differences have to be huge. Like, someone more than 30 kilograms, someone less than 16 kilogram per meter square. So, usually people in between 18 to 28 will have similar outcomes. It's the extremes which have, and most women, your 95% of the data will lie in that bracket. So which is why you don't see BMI related differences in IVF study, if at all, a very small difference. So, however, this idea that there can be multiple reasons why your IVF can differ, fertilization methods, okay, I thought that was a major flaw in our study. One group is being subjected to IVF/ICSI, and the other group is being subjected to PICSI. So that is for you to, because of course there will be time constraints, there will be practical issues, there will be people who can't pay for that treatment, right? These are the limitations of RCT. So you collect all that data, learn methods for how you match the variables. Propensity score matching, here you will not have that. That is one method, because you need very large data to be able to match, age, male semen parameters, source of egg, and all those. And then you kind of do a matching. It's a statistical software related thing. Or you do an adjusted analysis. Adjusted analysis is logistic regression, where you input multiple variables and then see where you're going. Again, you need large data for all these analysis. Large is like maybe in thousands to be able to get a meaningful result, but at least learn the method, right? Learn the method, know the limitations of your study, mention them in your discussion why you think the study is still limited. And it's always a good idea to take all inputs, right? Dr. Garima, I think you need, and thank you for
Yeah.
making, we'll
Yeah.
want
Yeah.
to.
Yeah. So it's indeed a very interesting study. Though I do agree with Dr. Archana that within the limitations, you could probably improve it by removing at least diminished ovarian reserve class 3 and 4, because that is definitely going to be a confounding factor. Age, at least age you will match, but for diminished ovarian reserve, with poor image and all, I think that could be one confounding factor. Now, can you go back to your last two slides where you have told us what are the outcome data you're going to collect? That's very interesting slides. Go back to the previous one, right? So here you have beta HCG positivity rate, implantation rate, clinical pregnancy rate, ongoing pregnancy, miscarriage rate between the two. So what test would you do as Dr. Ruma has taken the class? So what kind of variables are this and what test could you do for them for statistical
These
analysis?
are all categorical variables, and we'll be doing chi-square test, ma'am.
Okay, and go to the next one. Yeah. And what about fertilization and blastocyst development rate?
These both are continuous variables. We'll be applying a t-test.
Okay, fine. So now if you just tell me that in the present study, what is the it's a cohort study.
Yes,
So
ma'am.
your criteria for ICSI would be like which patients will you take for PICSI and which for regular ICSI?
Ma'am, it is a shared decision making between the patient, clinician, and embryologist. Pixie in our center costs around 5,000. So the patients who will be able, and plus if the embryologist feels slow, we usually do it in cases of advanced paternal age and recurrent pregnancy losses or RIF. So, but still, this is the decision between the clinician and the embryologist if the patient is ready to spend.
Yeah. So I
So
think
then
there'll be a lot
again,
of
Dr. Zilpa, so again, the indication for PIXI can also be one of the confounding factor for the analysis, isn't it?
Yeah, absolutely. Yeah, yeah. So, considering all these limitations, maybe a little more narrower inclusion and exclusion criteria would have done a better job. And suppose, yeah. So, if you have included all this data, how can you clean your data or, improve it?
Ma'am, we'll match, like if you are taking indications, if you are taking a patient with RIF in our PIXI group, so we'll try to match it with in the control group also, the same patient, so that the confounding variables reduce.
That's fine. But after you've given your results to the statistician, how can they improve it? How can they address the confounding factors? You can do a regression analysis, okay, with all the confounding factors, and I think they can do that. Dr. Uma, you would like to add to that?
No, all good. I mean,
Yeah.
perfect.
Sure.
Just that I want to add something here. I think why this is also being done is that for most men, more than 40, we are using some sperm selection method, irrespective of whether they've had recurrent miscarriages or not. So
Yeah.
PICSI is the selection methods, just like microfluidics done by the other speaker was. So we want to specifically PICSI in advanced paternal age. And there will be the confounder of time because controls are coming from a previous population and very less from the current population because men more than 40 more or less go through some selection method. So one would agree that that there are many limitations in an observational study and maybe larger data from so once we have our peak C population, Simran, what we can do is look at all women who are age matched. So this is, we will try and do a closest neighbor match. That's another way of matching. Women who are age matched, who are couples with semen parameters matched. So you have three categories: normal zoospermia, you have oligozoospermia, or you have SIP. So those three categories, you can match them because controls you can pick up. You can actually, because you have some 5,000 people, so you can pick these up individually. And everyone has to have a male age more than 40. So three variables you can match them on and then pick up your controls and see how the results kind of show up. So retrospective studies, I would agree, have limitations, but the data, real world data is only provided by these studies, like large data you can get.
Yeah, absolutely. Yeah. Just one comment about the title and the objective. If you can go to, is that the title of your presentation, that on the thesis?
Yes, ma'am.
No, where is the title? Can you show me the title? So here, when you say that PIXI for improving IVF outcomes in couple with advanced maternal age, here you are already inducing a bias because you're already implying that PIXI is going to improve. So it should be something more ambiguous as a title to make it less biased. Then go on to your objective aims and objective slide. Yeah. So aims, I understand you're comparing embryological and clinical outcomes with and without PIXI in couples with advanced. But when you talk about the objective, it has to be, intervention, control, and outcome. So here again, it's broad-based embryological and clinical outcomes. But basically, you must have used the study from which you have calculated the sample size. So what is the primary objective they have addressed? Is it live birth rate? Is it clinical pregnancy rate? Is it embryological?
Their
So that,
primary outcome was live birth rate, ma'am.
sorry?
Ma'am,
It
their
was,
primary outcome was live birth rate.
and so you also calculated your sample keeping the live birth rate as this,
No,
the
ma'am.
study?
We took
Your,
clinical pregnancy rate of that study, and the clinical pregnancy rate is the primary outcome in my study, ma'am.
so yeah, so your primary objective would be to compare the clinical pregnancy rate in couples with advanced paternal age undergoing this versus this, and the others could come in the secondary objective because that is what you're using to calculate your sample size, right?
Yes,
Yeah.
ma'am.
Yeah. So,
Thank you, ma'am.
yeah.
Thank you, ma'am.
Yeah. So,
Thank you, Dr. Simran, and thank you, experts, for your valuable opinion. And it was a very fruitful discussion for all of us. I would like to invite Dr. Bhavani for the closing remarks of today's session.
Thank you so much. Thank you to our mentor, Dr. Deepak Modi, and our convener, Dr. Ruma Satvik, for their excellent talks. I would like to thank all our esteemed chairpersons, our experts, and our dear fellows. And most of all, I would like to thank our audience for their active participation. And I hope we can take some learnings from this webinar and use it in our research. And this was the first module of the research methodology series this year, and we are hoping to bring you many more such webinars. Thank you.
Thank you.
Thank you.
Thank you.
yeah, thank you, Dr. Ruma and Dr. Archana, for having me.
you.
Thank you. Yeah.
Dr. Ruma,
Thank
Dr.
you. Thank
Bhavani,
you,
and
everyone.
everybody.
Okay.
Yes.
Okay. Thank you. Thank you.